Hi guys, today we will talk about acute respiratory distress syndrome ARDS. The definition of ARDS evolved over time, the most recent definition being that of the Berlin definition. According to the Berlin definition, ARDS is an acute, diffuse inflammatory lung injury leading to increased pulmonary vascular permeability, increased lung weight, and loss of aerated lung tissue, leading to hypoxemia and bilateral radiographic opacities associated with increased venous admixture, increased physiological dead space, and decreased lung compliance. The essential features of this definition being acute, meaning the onset must be over 1 week or less, and the bilateral opacities consistent with pulmonary edema on CT or chest X-ray, and the PF ratio, that is the partial pressure of oxygen in the arterial blood over the FiO2, must be less than 300 millimeter of mercury with a minimum of 5 centimeter of water PEEP or CPAP. And these findings must not be fully explained by cardiac failure or fluid overload. And the severity of ARDS may be assessed based on partial pressure of O2 in the arterial blood over FiO2, with 200 to 300 being mild and 100 to 200 being moderate and less than 100 being severe, with different mortality rates associated with them. Now, what are the risk factors for developing acute respiratory distress syndrome ARDS? There are some direct causes and some indirect causes. One of the most common direct causes is pneumonia. Pneumonia caused by the coronavirus is one example. Other causes include aspiration, contusion, embolism, etc. There is one scoring system known as the Murray score, which assesses the severity of ARDS, essentially in order to determine whether extracorporeal membrane oxygenation or ECMO is required for a patient or not. The scoring system uses various parameters like the PF ratio, the PEEP, the lung compliance, and the chest X-ray findings. With a score of 0, meaning no lung injury, and a score of 1 to 2.5, meaning mild to moderate lung injury, and a score of more than 2.5, meaning ARDS. Now, coming to the pathophysiology of ARDS, lung injury caused by any of the risk factor mentioned before cause a release of pro-inflammatory cytokines like interleukin 1, 6, 8, and TNF alpha, tumor necrosing factor alpha. These pro-inflammatory cytokines in turn causes three cascading effects like injury to alveolar capillary endothelial cells, activation of circulating neutrophils, and direct vascular injury. Now, injury to alveolar capillary endothelial cells and type 1 pneumocytes cause loss of normal tight alveolo-capillary barrier, leading to bidirectional flow proteins and fluid into the interstitial space and alveoli, surfactant and alveolar cytokines into the plasma. Similarly, activation of the circulating neutrophils cause sequestration of neutrophils in pulmonary microcirculation, which then get attached to the vascular endothelium and the lung parenchyma, and then this neutrophil degranulate to release proteolytic enzymes and toxic oxygen metabolites, which subsequently damage the capillary walls, leading to exudation of protein-rich fluid, the RBCs and platelets into the lungs, which obliterate the distal air spaces, the smaller air spaces. Another mechanism is direct injury to the vasculature, causing decreased pulmonary arterial blood flow to ventilated portions of the lungs, now leading to increased dead space and pulmonary hypertension. All this pathology ultimately leads to impaired gas exchange, decreased lung compliance, increased intrapulmonary shunt, hypoxemia, and clinically dyspnea. These changes can be said to occur over different phases. The first phase being injury, followed by exudative phase over the next 7 days, and then the proliferative phase over the next again 7 days, followed by the fibrotic phase and then resolution. Now coming to the ventilation protocol, if somebody develops ARDS due to any cause, they would invariably need mechanical ventilation. And mechanical ventilation is the mainstay of management for ARDS. The idea of lung protective ventilation in ARDS is not to cause any more injury to the lung while giving support for oxygenation. You achieve that by giving low tidal volume and a higher PEEP. Why low tidal volume? Well, in ARDS, parts of the lung is already injured, meaning it became consolidated due to infection or any cause. So the lung loses parts of its capacity to expand. That is, the compliance is poor. So if you give a normal tidal volume like 10 ml per kg body weight, the injured part will not move or will not expand, but the healthy part will overexpand, leading to again ventilatory injury. And a PEEP, that is positive and expiratory pressure, is kept on a little higher side to prevent the recruitment of alveoli, meaning the alveoli opened all the time so that gaseous exchange can occur in these healthy alveoli. So if you look at the chart here, the first step is to calculate the patient's predicted body weight, because somebody who is in ARDS won't be able to stand on a weighing machine to measure the weight. So you calculate the predicted body weight according to the formula, and then you set the initial tidal volume at 8 milliliter per kg body weight, and then you give a PEEP of 5. You select the lowest possible FiO2 that will give you a saturation of about 88 to 95%, and then you keep reducing the tidal volume by 1 ml per kg every 2 hours until the tidal volume became 6 ml per kg body weight, that is a low tidal volume. Now in the second stage, you adjust the settings according to the plateau pressure. If the plateau pressure is more than 30 centimeters of water, decrease the tidal volume again in 1 ml per kg increments until the plateau pressure is less than 30 centimeters of water, or until the tidal volume reaches 4 ml per kg body weight. Now, a tidal volume of 4 ml per kg body weight might be too low for effective clearance of carbon dioxide from the body. So in the third stage, you need to monitor arterial blood gases and look for respiratory acidosis. If there is acidosis, meaning the pH is between 7.15 to 7.30, increase the respiratory rate instead of increasing the tidal volume. You increase the respiratory rate until the pH becomes more than 7.3, or the respiratory rate is equal to 35 breaths per minute. Now, if the pH is very low, that is less than 7.15, first increase the respiratory rate to 35 breaths per minute, and if this does not correct the pH and the pH is still less than 7.15, you have no other choice but to increase the tidal volume in 1 ml per kg increments until the pH is more than 7.15. Apart from ventilatory management, there are non-ventilatory management as well for acute respiratory distress syndrome. Of these non-ventilatory managements, fluid management and prone positioning deserve special mentioning. And fluid management basically means restricted fluid therapy so as not to cause any fluid overload and pulmonary edema. Prone positioning for at least 17 hours in a day is seen to be quite effective in the management of ARDS. Last but not the least is neuromuscular blockade. It is advised that as soon as a patient is intubated and put on mechanical ventilator, neuromuscular blockade should be used so as to abolish or diminish a fight from the patient and better control of the ventilation. That is all for now. Thank you guys for watching. Please subscribe and share with your friends.